And I want to welcome Dr. Alexandra Abizaid from São Paulo, Brazil, joining us. It's wonderful to have you on our panel. We now have about 12 to 15 minutes or so. Thank you for giving that kind of time. And I've asked everyone to submit their questions in the chat function, which would be great. And for us to have a discussion around this. So, you know, it's a hard thing, isn't it? And maybe I'll go to you, Dr. Abizaid, first and foremost. You know, it's this high bleeding risk patients who we know have a complex disease, high thrombotic risk as well. How do you choose? Do you really think that a stent choice makes a difference? Are you convinced that we had to have randomized trials, or do you think that all the second generation drug-eluting stents are basically the same and it's agnostic to the stent?
I think this is a fantastic question. First of all, thank you so much for having me. Thank you, Sky and Roxana and everybody else. I think this is a very important question because I'm more and more convinced that this latest generation DS, they behave very similar in terms of safety. I think that we improved a lot, the platform itself, very thin struts. The polymer technology has been advanced so much during the past years, absorbable, even durable, but very with passive coatings, and not to mention the Limus drug. So I trend, to be very honest with you, Roxana, to favor the stents that we have more data. But I have a sense that there will be not a huge difference between all the latest generation DS in terms of safety performance. And again, I liked very much the slides that Bobby put together about that we have to do a good job in the cath lab. I think that we've been very slack and sometimes relaxed with such good technology that, you know what, just bold implant with 12 atmospheres and go home. I think that lesion preparation and imaging and to have an optimal result is a must. We cannot forget about that. This together with the latest technology, I'm more convinced that it's going to be very hard to understand the differences between the newest platforms.
That's it's great. Thank you for that. I'm going to call you guys with your first names. It's easier. So, Bobby, yes. Any additional comments to that? How do you choose in the cath lab, Bobby?
You know, it's a great question. I think with the evidence we have, it's pretty clear that the major stent platforms really all have led to an improvement in stent-related outcomes, including decreased stent thrombosis that was demonstrated in the 3 different programs. I think there are some differences in those 3 programs. And, you know, my disclosure is that I was on the steering committee of the Evolve Short DAPT study. But that, you know, I look at those 3 studies and there are some similarities between them, but there are some differences. And so if you're you know, truly data-driven, I think you should look carefully at the studies and look at the patients that applied to the patient population that you're thinking of and make sure that you are interpreting those the way that you would. For me, you know, in my heart of hearts, do I believe that there's a true difference in the stent platforms? I think it's any differences that exist there are easily superseded by the differences that we can make based on us doing the things that Alexandra just said, which is very meticulous PCI. I think that will, you know, overcome any of the small differences that might exist between platforms. So I am actually, you know, when I choose stents, I choose it not on the basis necessarily of what I think will be a DAPT outcome, but really based on the performance characteristics of the stent in terms of procedural performance characteristics, which I have some personal preferences for. But
so I think it was in your talk where it said, where you talked about lesion preparation, and a question came through the audience saying, where's the data for lesion preparation and outcomes? And it's a good question. And I think that the data is not about lesion preparation, I don't think. It's about having a good final result, and the final luminal diameter being a very, very important predictor of outcomes. Would you guys have anything, and usually you get a really good final diameter, you're able to get a final luminal diameter or the minimal stent area will be largest with a better lesion preparation. Do you guys agree with that? And I just want to make sure that I'm not overstepping my answer to this question, because there is no, we don't have data on that, obviously.
But I agree with you, Roxana. We do have indirect data because, as you mentioned, try to follow patients that will have lots of calcium, that you don't do a good job with preparation or ablation, and then this patient will have an underexpanded stent. The likelihood that this patient will come back with thrombosis or restenosis is much higher. So it's about the final result. And to get a final result, sometimes you have to spend a little bit more time preparing the lesion.
So Kate, you have a high bleeding risk patient. You just put in a very long stent. Now they have these really long stents, 48 millimeter stent after you open the CTO of your patient. And of course, you did a beautiful job, and you used imaging. You got the best perfect result. But this patient is high bleeding risk by every criteria. So at 1 month, what do you do? What do you do if they presented with an ACS? Well, with a CTO, probably not, but you know, how would you do this?
Yeah, even so with overlapping, I think a common question that comes up is if specifically in the CTO population, if we should commit to a longer duration of DAPT, or just similarly complex calcified lesions in these patients that are higher risk for bleeding as well. And, you know, that specifically, they just by definition are a stable ischemic heart disease patients. So I think from a physiologic perspective, we feel very comfortable stopping their DAPT earlier. And in many cases, we will drop aspirin if there's some other concern or interaction. Excuse me. But I think in the patients that are high bleeding risk who have, you know, even the case that was shown that was not an ACS presentation, but a fairly complicated lesion, the operator had actually intended to do atherectomy, but in running into difficulty with the diag shutting down, felt obligated to kind of get a stent in and get out of the lab. And I think just as alluded to, those are the cases that are challenging. In all the patients where we get that most immediate feedback in the lab from intracoronary imaging, I feel much more comfortable stopping their DAPT really, you know, as early as necessary after 1 month, if the clinical situation warrants that. What's that?
Were you stopping at 1 month?
Well, honestly, we'll typically stop aspirin as soon as they're getting out of the lab if there's a real issue with it, that once they've been loaded, you know, we're not really too concerned about that once the P2Y12 inhibitor kicks in. And some of that's just maybe an overlay of bleeding risk patients and the more experience we got with that and being comfortable. But so typically doing that, and in patients, especially once they're out to the 3 to 6 month window, we'll switch them back to aspirin if it seems to be clinically indicated. Obviously, if they're low bleeding risk, I think it's a different conversation. And the patients that I'm most concerned about in a CTO or other cases are where there's an outflow issue or there's something about stent optimization that couldn't be achieved at that time that you're coming back for. So I think those are cases that come up more as opposed to some very specific detail from the case.
Are any of you using the strategy with a P2Y12 monotherapy, and do you feel comfortable to do that with clopidogrel without testing patients for non-responsiveness? So let's start with you, Alex, and then I'll go sort of around Bobby and then Kate.
Yeah. There are a couple of studies here in Brazil that start enrollment with monotherapy. A little bit like what you did for Twilight, but even more aggressive with no aspirin early on with prasugrel, for instance. Quite frankly, if I have a patient with high risk for thrombotic events, I don't trust clopidogrel only, unless if I can test to see if the patient is not resistant. But this is an exception in my practice.
Bobby?
Yeah, I feel similarly. I know that there's good randomized data supporting clopidogrel monotherapy in randomized trials, but it's important to remember that most of those trials come in Asian populations where we think the ischemia bleeding balance is different. I think in a Western, US or Western Europe population, I would have concerns. And so I haven't done clopidogrel monotherapy apart from in those patients who have anticoagulation, so clopidogrel, monotherapy in addition to like a DOAC, for example, that we certainly do more commonly, and we're comfortable doing that almost immediately right out of the gate, considering what was done in studies like Pioneer, et cetera. But But I do feel more comfortable with ticagrelor monotherapy. I would feel comfortable with prasugrel monotherapy. We don't tend to use much prasugrel. Maybe we should do more, but usually when we do P2Y12 monotherapy, based on the strong evidence that you, Roxana, produced, I think we feel very comfortable with that approach. My only concern there is for those patients who have dyspnea and what will happen if they were to discontinue. So we have a careful discussion with those patients about really being careful, if that's the case, not to discontinue on the basis of, some side effect they believe or not missing doses because of the BID drug. But other than that, I think the safety profile is really strong based on the evidence you've produced.
Well, the nice thing about the dyspnea is that you would know that while they're on aspirin, because there'll be some duration that they're on dual antiplatelet therapies, unless you're going directly to ticagrelor monotherapy.
Yep.
And I think that was sort of why we did not show an issue with in Twilight. It's really important for people to note that that issue that Bobby just brought out is a really important one. We did have about 8 or 9% of our patients complaining with ticagrelor shortness of breath and stopping it during that 3 months before they were randomized to ticagrelor monotherapy versus ticagrelor plus aspirin. And in those cases, most of those patients switched off to prasugrel and were never randomized in Twilight. So please note that this is an important issue. Usually those patients, that's another reason why I think discharging patients on ticagrelor monotherapy is a little bit dangerous, not knowing, and maybe that duration doesn't need to be 3 months, maybe 1 month, maybe 2 weeks, I don't know, but certainly it's important to make sure that they're not going to stop altogether and that you follow them really closely. Kate, have you practiced this at all, or are you, do you have any comments about?
Yeah, we seem to have several patients who there's concerns or, overlapping other issues. And so we've dropped them down. If they have a personal track record with clopidogrel, I think we've been pretty comfortable with that. In this, again, I think in the stable ischemic heart disease population, those events are few and far between if they're consistently and they're adequately, if the drug is active at that time. So in patients who are having ad hoc PCI and loaded around that time, I'm much more hesitant, or in the ACS population or some other issue. But yeah, otherwise we've shifted to that pretty frequently in patients who are also being treated for cancer, these other overlapping issues, and have had a pretty good track record with that.
We have another 5 minutes, and Larry Dean puts up a really nice question, and I have the same question. It's about the non-stent related events. Bobby, you're best to answer this, and I think the impact on non-stent related events and the prolongation of DAPT is incredibly important. But if you had to do the DAPT trial over again, knowing what you know today, how would you randomize the patients, and what would you do differently for those exact same patients?
Yeah, it's a great question. I mean, I think that we would certainly, we had 50% of the stents not be current DES that we use. So we would update that in terms of using modern DES. And I think we would compare 2 different durations of dual antiplatelet. It wouldn't be 12 versus 30. It would probably be something shorter versus 12 potentially. And there might be a stratified analysis for HBR patients. I mean, I think we're going to see a really interesting study.
I would like to see the single antiplatelet regimen of aspirin alone versus P2Y12 alone,
Yes.
P2Y12 monotherapy, because that's never been evaluated. Yep. Except for the Capri trial, where we did show an important benefit for clopidogrel monotherapy over aspirin, actually, with even less bleeding, especially GI-related bleeds. And I think that it would be interesting to kind of think about that. Last question, last couple of questions. One is the role of Repatha. I find that very, very interesting. I don't know how many of you know, but I pitched a study on high bleeding risk patients where we've kind of we really want to maybe change the pathway that we're treating. Instead of pushing the antiplatelet regimens, should we be pushing the lipid lowering regimens? Anyone have any thoughts about that? What are you doing in those HBR patients? Are you pushing down the LDL into the basement? Kate?
I think we've just really continued with standard therapy, but it's an exciting area to stay tuned.
And then lastly, because we have 1 minute, I have to ask this because it comes through the chat. What are your thoughts about platelet function testing? Just quickly, thumbs up, thumbs down. Let's go for everyone. Your routine use. Here's mine. Selective use when you're dropping aspirin on clopidogrel with high-risk patients. Are you like kind of, Kate, where are you on that?
We rarely use it, but occasionally.
So you are that way. Okay. So you'd go to clopidogrel monotherapy. Genotyping, anyone thinking about genotyping? We don't do it. Anyone does it? I mean, it was Taylor PCI was interesting, right? The early 90 days guiding that was very, very interesting in the first 90 days. But anyway, guys, it's been a fantastic, fantastic session. Dr. Carney, thank you for your incredible lecture. Thank you for teaching me about how to give a good lecture on this. Bobby, as usual, Dr. Ye, fantastic. And Dr. Abizaid, thank you for making time in this late time and being with us. I know how busy you all are. It's a fantastic start to SCAI 2021. Keep joining us, keep learning. Bye, everyone. Can't wait to see you all in person.